Okay, there we go. Okay,
All right.
thank you for your patience, Dr. Mason.
Absolutely.
I think everybody here knows you or knows of you. I'll just take a brief time to say a few words. I believe you're a graduate of Dalhousie
Yep.
and your home residence is Stellarton,
New Glasgow, actually. Grew up in
actually
the West.
Glasgow. So
Yeah.
he's a hometown son. He's a graduate of the urology program at Dalhousie, and he went off to Minnesota to specialize in robotic treatments of cancer. He spent a couple of years there, and he brought back the knowledge and the technology to Nova Scotia. So with further ado, Dr. Mason's going to talk to us about the robotic program and the new opportunities to treat prostate cancer. Dr. Mason, it's all yours.
Perfect. Well, super excited to talk to your group again. Always lots of enthusiasm, and I know you spoke with Dr. Gabriella Illy, and she was very happy with speaking with your group as well. And so what I wanted to do a little bit tonight was talk about prostate cancer in general and talk about what we're doing at the QE2. So I am going to focus a little bit on robotics throughout the talk, but also just on the whole. What are we offering today? Because when I started in urology 13 years ago, it was a lot different. We had very limited options compared to what we have today. And through significant efforts by my colleagues around the globe, there's been huge strides made in prostate cancer treatment, and there continues to be. And so I just kind of wanted to share some of that enthusiasm about prostate cancer research and treatments that we have going on. My practice is in treating cancers of the urinary tract. About 50 to 60% of that is prostate cancer, and my research is heavily based in clinical trials in prostate cancer. So I figured we'd go through that. Please interrupt me at any time, and at the end I can talk about this stuff or anything else. So we'll get going here. So let me just talk. So my objective is really, I'm going to talk about, what are the various stages of prostate cancer, how do we treat based on that stage, and a little bit about side effects, because when we're choosing how we're going to talk to our patients and people with prostate cancer, one of the big things is, how is this going to impact them? What does it do in terms of side effects? So, how do we diagnose prostate cancer? I think many of you would be familiar with this. We do it with blood tests. The PSA, it's been a controversial blood test, but it does work. It's how the large majority of men are coming to us. We do see some men that present later who did not have PSA testing, and they do have symptoms related to their cancer, things like difficulty with peeing and pain in various parts of the body. And then the diagnosis is confirmed with a biopsy, which I think many of you have probably gone through, and some imaging tests. And I didn't really focus on it here, but we biopsies have changed a significant amount over the past 10 years as well. We have our standard prostate biopsies that we're doing, but we also have the ability to use pretty fancy imaging with MRI to actually target exactly what we're biopsying. And so we've gotten a lot better with that too. And that technology has been at the QE2 for the past 16 months, courtesy of the QE2 Foundation. So when we look at prostate cancer and someone comes in and we're seeing them, we try to put them and say, okay, where are we in terms of this disease? Is it what we call localized disease? And that means it's just in the prostate. It hasn't gone anywhere else. It's just there. Is it so-called what we call locally advanced prostate cancer? That would mean that it's just starting to spread around the area where the prostate was or is. We have this word called metastatic. Metastatic is just a fancy word that means cancer has spread somewhere else in the body. That's all it means. And then we have a final stage of prostate cancer where we say it's actually been resistant to some of our treatments. So despite all our best efforts in treatment, the cancer continues to grow. And that is the later stages, and that's called what we call castrate-resistant or hormone-resistant prostate cancer. So localized prostate cancer, that's where robotics come into. This is when prostate cancer is just in the prostate. It's not growing into things that are around the prostate. It's not spreading to other parts of the body. And we often look at this disease and we say, is it a low risk, somewhere in the middle called intermediate risk, or is it a high risk of this getting worse? And that helps us in terms of how we're going to treat this. And so this is kind of a picture of that. This is the prostate gland. The prostate is a finicky little organ. It's tucked deep in the pelvis, as you're all aware. Its sole purpose is a reproductive organ. It makes semen, and it's the most common site that men get cancer. It's actually the most common solid organ cancer that exists out there. So it is a very common disease. So how do we treat this? Well, it depends, and it depends on a lot of different things, but we can do what's called active surveillance, where we're monitoring actively and treating when needed. We can do what's called watchful waiting, and I'll talk about what the difference between watchful waiting and surveillance means. There's surgery, that's where robotics comes in. And then there's radiation therapy, and radiation therapy has exploded in terms of our capabilities. Essentially at the QE2 right now, we offer everything that you can find, save for a few things that you can only get in the United States, but we pretty much offer the gamut for radiation therapy. Active surveillance, some of you may be familiar with this. This is generally when we think that men are at a low risk of the cancer getting worse. We don't think that it's going to get worse quickly, or that we're going to miss this opportunity to cure somebody. And so the goal is to monitor somebody pretty closely and only treat them if needed. And that way we can avoid side effects. We don't get all the side effects of treatment. This is a little bit different than, and so how we do this, we monitor the blood work. We do a physical exam, as you're all aware of. We do a prostate MRI. This is new probably in the last 5 years. We do an MRI, that's an imaging test that looks at the prostate. And we do that in every man on surveillance, or at least I do. And sometimes it involves other biopsies as well to see if the cancer is the same. This is a little bit different than what we call watchful waiting. Watchful waiting is generally in patients that are older and have other health issues, and really just monitoring the cancer to make sure that it doesn't harm them and treating them if it's at risk of causing harm, as opposed to going for a cure. And so we do this in many patients as well that might be a bit older and have other health issues. But so it's a little different than surveillance, where the goal of surveillance is still cure, just hopefully the cure is never needed. But then we get into my realm. My world is radical prostatectomy. This is surgery for prostate cancer. The word radical just means complete removal. And so it means removing the whole prostate. We often will remove some of the lymph nodes. Lymph nodes are like little balls of tissue that surround a prostate that cancer can spread to. And we did this through an open approach for many, many years, since well, the first prostatectomies were described in the early 1900s in Johns Hopkins. But they really didn't get popular until the 1980s, when people figured out safe ways to do this through open approaches. And we did that for about, well, here in Halifax, we did that up until 2019. This February 1st, we'll celebrate 5 years of robotic surgery. And to date, we have done 1,300 robotic surgeries. And with that would be about 1,000 of them being prostate removals. And that is between two surgeons, myself and Ricardo Rendon. And we've just actually hired a third. We have a third robotic prostate surgeon in Halifax. Her name is Dr. Andrea Kokorovic, and she's just joined us to help provide care to prostate cancer patients throughout the Maritimes. Robotic surgery, this is essentially the keyhole surgery. So we have been doing what's called laparoscopic or keyhole surgery for many, many years. Take gallbladders out with it, we take kidneys out with it. You can do lots of surgeries. The one thing about prostate removal is it's a tricky operation. It's a tricky place to get to, and doing it with just fine little sticks with your hands was challenging, and not many people actually did that. They did the open approach. When we got robotic technology, robotics allowed us to do minimally invasive surgery with cameras easier. We can do a finer job, and the robot really makes that doable. And the advantages of robotics are very clear. You get better visualization. We see a prostate in 10 times magnification in 3D view about 2 inches from the prostate. We never saw that in open surgery. There's less blood loss, less postoperative discomfort. Most of our patients go home the next day. I would say 9 out of 10 go home the next day, and there's probably improved outcomes in the long run. There's nothing wrong with open surgeries. There's lots of surgeons in Nova Scotia still doing the open prostate surgery, and many of them are very, very good at it. But there certainly is some advantages to the robot. Well, I've certainly, maybe I'm a little biased, so take that for what it's worth. But we solely believe in it. When we switched to robotic surgery in 2018, I think probably the number of open surgeries that we've done for prostate surgery in the last 2 years is maybe 1 or 2 out of several hundreds. So what is robotic surgery? Not at least currently, it doesn't do any operations on its own. It's essentially a tool that allows me to move the instruments inside a patient very precisely. The surgeon still is completely in charge of the operation, so we don't. There is no autonomous movements. It just makes fine movements easy, and makes like things like suturing or that sort of thing makes it a lot smoother and more precise. So, and that's a common question we get is, what is the robot doing? Well, the robot really is doing nothing other than what we're telling the robot to do. So that's robotic surgery, and we'll come back to that towards the end. Radiation therapy is another good treatment for prostate cancer, and it is offered in 3 different ways currently in Halifax. We can do what's traditional, which is called external beam radiation therapy, which is still a very good treatment. This is where X-rays are delivered over a period of several days. That number of days has gone down over time. It used to be 35 days. Now, in terms of treating prostate cancer up front anyway, that means not having had surgery before, it's only 20 days. It's pretty precise and used in 3D space. We just started a program called SBRT, or something that you'll see probably advertised if you've ever been to the US, called SABRE, which is essentially using external beams, but you're using in a very defined way or very refined way. And instead of doing 20 days, we can do 5 days of treatment. So we're shortening up how long it takes us to deliver radiation, which is a huge benefit when people are coming from farther away and they're not in the city. To not be in the city for 20 days and be only there for 5 days is a big deal. And then we do something called brachytherapy, and brachytherapy is like probes placed in the prostate. I don't know if anyone's familiar with or heard someone who's had gold seed treatment. They used to put gold seeds in the prostate for prostate cancer. Nowadays, what they do is they put these probes, kind of like a biopsy, right into the prostate, and it can deliver radiation, again, in 3D space, to deliver the radiation right to the prostate. A very good treatment for many patients, and provides pretty high cure rates with brachytherapy. I'm going to give a nod. I don't know if anyone is familiar who this picture is. Androgen deprivation. We call this hormonal treatment. Anyone that's been on hormone treatments for prostate cancer will be aware of this. Essentially, that male hormone, testosterone, that is the signal that causes prostate cancer to grow. That's like its food source. Without testosterone, most prostate cancers will not grow. And if you take away that signal, that prostate cancer, the cancer will shrink. It actually starts to shrink away. And this guy here is from the north end of Halifax. He went to Acadia University, and then he went to Harvard, and by way of Harvard went to Chicago. And this is Charles Huggins. He won the Nobel Prize. He's one of a handful of Nova Scotians to win the Nobel Prize, and he actually discovered this pathway. He discovered that if you take testosterone away, then you will essentially induce a remission, at least for a period of time, in prostate cancer. So a Nova Scotian who's made a big name for themselves in terms of prostate cancer treatments. And we add this to radiation in some patients because it's been shown to improve outcomes and survival. How do we choose? So yeah, we're choosing between surveillance, surgery, and radiation. Well, this is where it gets difficult. I often say that I treat bladder cancer, and sometimes the only treatment is surgery. It makes my decision and the patient's decision very easy. Here's your one treatment. This is what we're going to do. Prostate cancer is not like that. Prostate cancer has a whole bunch of different things we can offer. We just talked about a lot of them. And so we have to actually sit down and come up with the best plan for anybody that's in front of us. And that often is the patient's choosing. So you guys choose, and here's the options that we can offer. Here's the potential side effects. We're going to guide you through, but it's ultimately your choice. sometimes other health problems, maybe surgery is not the best idea, or maybe radiation is not the best idea, depending on other health problems. And then often how much cancer is in the prostate, because if there's a lot of cancer in the prostate, then sometimes surgery is actually not the best plan, because it's actually hard to get it all out from a surgical approach. So that's kind of, we're spoiled with a lot of options for prostate cancer, but sometimes it makes the decisions not clear cut. But we talk about side effects, and unfortunately, there's side effects with all of our treatments, and that's one of the problems that we have. We've certainly gotten much better, with surgery or so-called radical prostatectomy. Leakage, wetting yourself, that incontinence, that is a risk. That has gotten much better with the introduction of robotics and with refinement of surgery, but it is still present. Erectile dysfunction can happen with both radiation and with prostatectomy. We've gotten better over time, but it's not perfect, and that's a common side effect for many men. And then obviously the risks of surgery that are standard to all surgeries, and the side effects of hormonal treatments in men that are going to get those treatments are something we need to consider. And then one thing that we've kind of ignored, but Dr. Illy that spoke with your group is very heavily involved in, is the mental health aspects of prostate cancer treatment, because obviously it takes a big toll in terms of anxiety and stress and other pressures that we can't ignore. So that's kind of how we treat prostate cancer within the prostate. And then this is where it's, those are really exciting because you've got those new treatments. But when we get into prostate cancer that might be a little bit worse, this is where we've really improved survival. Some of the new drugs in the market have improved survival like several fold. When we had none of these new drugs, the average survival if prostate cancer had spread to other parts of the body might have been counted in 1 or 2 years. The average survival, if it's spread elsewhere now, is in excess of 8 years and increasing. So we've made huge gains in treating prostate cancer. So locally advanced disease, when we call it cancer, we don't want to say it's spread to other parts of the body because it hasn't, but it's spread into some of the areas around it. We call that locally advanced. So it's still just in the prostate, but now it's starting to grow into some stuff around it. It might be growing into other organs like the bowel or the bladder, or it might be spread to those so-called lymph nodes, those little balls of fat. But it hasn't spread other parts to bones and things like that. We usually treat this with radiation therapy and with the hormonal treatments. We can add in some pretty fancy medications that are available in Nova Scotia in select cases, and we do surgery in some of these cases, but not all of them. Oftentimes surgery, you will leave cancer behind, and we find that that's not the best approach, but there's certain cases where we do that because it is the best approach. Now, metastatic prostate cancer. So there's some cool stuff going on here. And by cool, I mean some really impressive stuff. And there's some stuff that's coming soon. This is where prostate cancer, unfortunately, has left the prostate and gone to other parts of the body. Prostate cancer, for whatever reason, has an affinity for bone. Prostate cancer spreads to the bone. That doesn't mean you have bone cancer. That means you have prostate cancer in the bones. And it's a little bit of a funny thing, but cancers in the body, where they've started is where they're from. If you took a piece of a bone tumor that started in the prostate and you sent it to one of our pathologists, they'd put it under a microscope and they'd say that looks like a prostate. So it is as opposed to thinking it's bone cancer, it's prostate cancer that's gone into the bones. Less commonly, it can go to things like the lungs and the liver, and rarely it goes to the brain, but that's a pretty uncommon scenario. When we get to this point, this is where we've made huge gains. This is not something, at least currently, that we can cure in most cases. The goals of treatment are to extend life. So that's our big goal, is to make people live longer. We want to make sure that people don't have symptoms, that they're not getting pain and other troubles from the cancer. And we also want to make sure that our treatments are tolerable, so that we're not trading one problem for another, because that's not what we want to do. So how do we treat it? Well, we'll use, these are big words, and I don't mean to focus on these. These are just, some of you may be on some of these medications, and being on these medications is something that we do. And so we use the hormonal treatment. We lower testosterone levels, and for millennia, since the 40s, that's what we did. We 1940s, when Charles Huggins figured this out, we lowered testosterone levels. And we did that until about 2015. And in 2015, up until 2021, there was a multitude of new clinical trials showing that adding these advanced drugs increased survival several fold. And so we use the hormonal medications, but we add on these new medications that drastically improve our survival. And they not only improve survival, but they prevent people from having side effects. They prevent people from having bone breakages and pain and things like that. So in our opinion, in my opinion, as someone who works in the world of oncology, anybody with advanced prostate cancer should be placed on one of these medications. And they're widely available. They're not without side effects. So these medications that lower testosterone levels result in significant fatigue, sexual dysfunction, hot flashes, weakening of the bones, increased fat. So we have to talk to people significantly about how we manage these side effects. So we're not naive enough to think that people don't struggle and have troubles on these medications, but we work with people to try to mitigate some of those side effects. And then at the end of the line, this is where there's a lot of work being done, and we've got clinical trials that we're doing where prostate cancer, despite giving these advanced treatments, has continued to grow. Treatment at this point gets pretty individualized and complex. We can use chemotherapy in some cases. And then the one thing I want to mention, because some of you may have seen it in the Chronicle Herald, is something we call radioligand therapy. And radioligand therapy is really cool. So this is what lutetium and PSMA is. I don't know if anyone's familiar with what PSMA is. PSMA is a type of imaging test. It's a PET scan, and a PET scan specific to prostate cancer. So PSMA is a scan, and now we have it available in Halifax, and it is very, very specific for prostate cancer. If you have prostate cancer that's spread anywhere else in your body, a PSMA scan will light that area up. You can see on the left side of the screen that all those little black spots, all of the little black spots, except the big one, that's your kidney, but all of the other little black spots are prostate cancer. And that PSMA scan showing all those areas of prostate cancer. Well, somebody got very smart and said, well, if this imaging test, if this molecule that you put in somebody and then x-ray them can light up prostate cancer, can you put some radiation on that molecule? So they have actually designed the molecule that runs this test. It gets injected into your arm, into your IV, and that goes to all of these black areas and delivers radiation directly into those areas. And you can see that on the right side is after the treatment. And you can see after a couple months of treatment, pretty much all of the black spots, except the ones that are not cancer, those would be the kidney and the bowels there that we're seeing, the leftover stuff in the middle, but all of the other spots that were prostate cancer are shrunk away. And this is really cool stuff. And this is this treatment, the imaging test that we see there on the left, these imaging tests are available at the QE2 as of the end of September. This treatment should be available in March. And so we've done this on clinical trial so far, but this should be actually something that we're going to be offering our patients with cancer spread, and it really is going to revolutionize what we're doing. So that's kind of how we treat prostate cancer. We try to base our treatments on everybody as an individual. So no two people that come through our door are the same, and it depends on the patient's wishes, some of their other health issues, where the stage of disease is and what's available. We do have almost everything in the world of oncology that would be considered guideline care. There's a few niche things that we don't have available yet. A team approach is needed. So we have a lot of people that help us treat prostate cancer. And then we have to consider a lot of other things like side effects, the genetics, are you going to pass this down to your family members? That sort of thing is becoming more and more important. And our team considers a lot. So we have people like myself. I'm a urologic oncologist and a urologist. We have our radiation doctors. We've got our medical oncologists. Those are chemotherapy doctors. We have an amazing prostate cancer nurse. Our prostate cancer nurse, Liette, is probably one of the most experienced people in the country in helping manage prostate cancer. Our pharmacists, our mental health experts, and our radiologists who read all our x-ray tests, and our pathologists who help us read all our biopsies really make a big team. And those are my kids. I go to karate with them on Tuesday night. but that's what we're doing at the QE2 right now, right? You know, our robotics program has I think, been probably one of the best robotic programs in the country. You know, we had a great team that started it, and we really moved it along. And sometime last year we did our 1,000th case, and now I think it's around 1,300 or something. So, so we are doing lots of them. I think, yeah, by the hundreds. So. Thanks for listening to me. I'd love to hear any questions you guys have or talk about anything else related to the prostate cancer. So,
Are there any questions that